Okay, there we go. Okay, welcome everyone. It's so nice to see some familiar faces. It's a small group, but I think it's going to be super interesting because we're all from different centers. Dr. Hassanien is our presenter today. He's an assistant professor of medicine at University of Mississippi Medical Center. He's a super smart colleague, and I've learned a lot from him in both the realms of glomerular disease and onconephrology. So we have a super interesting paper to discuss. Some of you are authors on that paper, so thank you for that. But looking forward to the presentation and the discussion. And of course, we always thank our sponsors, Renibus and BTG, for the educational series. And we really hope that this article will become, this session will eventually turn up as an article on JON that we can spread. And we want to get the different views together. So hopefully we can hear some different practices today. Go on, Mo.
Thank you very much, Harish, for the very kind introduction. I have no conflicts of interest to disclose. And basically, this is the article that I will be discussing today. So this is an article that was published in the Journal for Immunotherapy of Cancer in 2022. Shorter versus longer corticosteroid duration and recurrent immune checkpoint inhibitor associated AKI. It's a multi-center study that was basically led by Dr. Shruti Gupta, who's actually one of the co-founders of the American Society of Onconephrology. I'll just start with a very brief introduction. So as we all know, targeted immunotherapy has revolutionized cancer treatment, and immune checkpoint inhibitors have been on the forefront. Now, immune checkpoints, as most of us know, these are natural breaks that basically halt the immune activation of our immune system against tumor cells. And basically, these are comprised of different antigens and proteins and ligands. CTLA4 is one of them, PD1 is another one, and PDL1 is another one. So if we basically take a look at this figure here, so once the tumor cell expresses the antigen, the antigen binds to the T cell receptor, and then PDL1 binds to PD1. And when that happens, it basically prevents the T cell from attacking the tumor cell. However, when we basically block the PDL1 or the PD1 with basically medications, with immune checkpoint inhibitors, that basically stimulates that T cell to kill that tumor cell. Now, the FDA approved several immune checkpoint inhibitors, starting with ipilimumab, which is a CTLA4 inhibitor that was in 2011, and then PD1 inhibitors, and then PDL1 inhibitors. And these have been used either just one medication versus like combo medications and in the treatment of different types of cancers. As you know, if we unleash the immune system, basically that will lead to immune-related adverse events that can happen in the whole body. But for the sake of nephrology, we focus on AKI and nephritis. And then AKI, the patterns of injury, the most common pattern of injury is acute tubular interstitial nephritis. And that is found to be actually one of the risk factors is actually concomitant PPI use, and that was a paper that was published in CJASN a couple of years ago, and that was a study led by Harish actually. ATN is the second most common pattern of injury. Glomerular injury also happens and varies, including minimal change, membranous IgA nephropathy, FSGS, and post-immune GN, and also TMA. This is a figure that was published in ASN Kidney News. Basically, immune checkpoint inhibitor AKI, the timing varies, but the median is around 16 weeks from immune checkpoint inhibitor initiation. As we mentioned, acute tubular interstitial nephritis is the most common lesion. UA is neither sensitive nor specific. Risk factors include PPIs, which lower the immune threshold for the immune system basically to identify the normal tissues as basically foreign, lower baseline GFR and immune-related adverse events. Renal recovery has been observed in 2 out of 3 of patients, and early steroid treatment had a higher odds of renal recovery. And then basically in terms of re-challenge, recurrent AKI occurs in 1 in 5 patients who are re-challenged with immune checkpoint inhibitors. Now, how do we manage? We really don't have a consensus. Different societies have different recommendations. So this is basically the National Comprehensive Cancer Network. This is the Society for Immunotherapy of Cancer, and this is the American Society of Clinical Oncology. And because the most common lesion basically is acute tubular interstitial nephritis, corticosteroids are basically the mainstay of treatment, in addition to holding the immunotherapy versus permanently discontinuing it. And as you might see, basically there is no consensus. However, because of that, we really don't know how long we should continue corticosteroids. So I think that's the million-dollar question. So for how long should we continue steroids? And this is a very important question for several reasons. One, because we worry about steroid-related side effects. Also, it is postulated that steroids may blunt the anti-tumor efficacy of immunotherapy, which in turn could preclude re-challenge with immune checkpoint inhibitors. So this was the main question that the authors aimed to address. So the authors compared a shorter versus a longer corticosteroid duration, and a shorter duration was basically less than 4 weeks compared to a longer duration, which was from 4 to 12 weeks. And this is another paper actually that the same investigators, the immune checkpoint inhibitor AKI consortium investigators, published in 2021, and they looked into the basically the epidemiology and the outcomes of these patients. So the authors used the same cohort. So this was an international multi-center cohort. The original cohort was from 10 countries and 30 centers. Now, for the sake of this study included 9 countries from 29 centers from January 1 of 2012 to December 31st, 2020, with AKI that was defined according to the KDIGO guidelines, and AKI was directly attributable to immune checkpoint inhibitors. And how did the authors define that? So one, the AKI was directly attributed to immune checkpoint inhibitor use by the treating provider, and either one of these criteria was present. So either there was an increase in serum creatinine more than or equal 100% from baseline, or requirement of kidney replacement therapy, or an increase in serum creatinine more than or equal 50% from baseline, plus one of the following: either acute tubular interstitial nephritis on biopsy, immune checkpoint inhibitors that were held for at least 1 cycle due to concern for immune checkpoint inhibitor-induced AKI, and treatment with corticosteroids due to concern for immune checkpoint inhibitor-induced AKI. So the patient population, they received high-dose corticosteroids, which was more than or equal 40 milligrams of daily prednisone equivalents within 14 days of immune checkpoint inhibitor AKI diagnosis. And corticosteroids were tapered to less than 10 milligrams within 12 weeks, which is equivalent to 84 days. And the reason why the authors chose 12 weeks was because of the distribution of the data. So the authors found that 88% of patients on corticosteroids had corticosteroids actually tapered within 12 weeks. as we can see in the figure. And then basically the original cohort was comprised of 429 patients. These were the exclusion criteria. 264 were excluded for various reasons, including corticosteroids that were initiated more than 14 days after the AKI onset, those who are not treated with corticosteroids, those who are on corticosteroids for more than 12 weeks, those who were on a lower dose of corticosteroids, less than 40, missing incomplete data, patients that were already on steroids more than 10 milligrams at the time of the diagnosis, patients who had a primary lesion other than acute tubular incision nephritis on kidney biopsy, those who died within 28 days of initiating corticosteroids, and that's to avoid immortal time bias, and those who were basically treated with non-corticosteroid immunosuppression at the time of the diagnosis. So they basically included 165 patients in the analysis. 56 patients received shorter duration of corticosteroids, which was less than or equal 4 weeks, versus 109, which is approximately 66% of the 165 that were on a longer duration of corticosteroids. The primary objective was the incidence and the time to recurrent immune checkpoint inhibitor-induced AKI within 30 days of completion of corticosteroid treatment. And what they meant was, by completion of corticosteroid treatment, was the fact that corticosteroid was tapered to less than 10 milligrams. Now, recurrent AKI within 30 days was defined as an increase in serum creatinine more than or equal 50% compared to the creatinine at the completion of corticosteroids, AKI that was directly attributable to immune checkpoint inhibitors by the provider, or AKI that was retreated by reinitiation or escalation of corticosteroids. They also looked at a composite outcome of recurrent immune checkpoint inhibitor-induced AKI, or death within 30 days of completing corticosteroids. The statistical analysis, baseline characteristics, categorical data was they used the chi-square or the Fisher's exact test, continuous data. They used the student's t-test for uniformly distributed data, or Wilcoxon-Rankin sum test for skewed data. They used Kaplan-Meier curves or the log rank t-test for analyzing the time to recurrent immune checkpoint inhibitor-induced AKI or death. And they also did a sensitivity analysis and looked into the incidence of recurrent immune checkpoint inhibitor-induced AKI only in patients with biopsy-proven immune checkpoint inhibitor AKI. A p-value of less than 0.05 was considered statistically significant, and they used the SAS version 9.5 for analysis. This is the baseline characteristics. So as you can see, these are the patients who received a shorter duration of corticosteroids compared to a longer duration. 56 patients, that's approximately 34% of the cohort, were received a shorter duration compared to 109, which is approximately 66% of the cohort. As you can see, the baseline characteristics, the age, gender, race, and the comorbidities were pretty much equally distributed across both groups. What I did notice is there were actually no patients with COPD on the shorter duration arm in the shorter duration group compared to 17 in the longer duration group, with a significant p-value. But other than that, the characteristics were evenly distributed. Here, they basically looked at baseline eGFR, which they used the CKD-EPI equation using the closest serum creatinine before immune checkpoint inhibitor initiation. Once again, the median GFR was, like everything was pretty much evenly distributed, including extrarenal immune-related adverse events, including the type of malignancy And these were all non-statistically significant, except the duration of corticosteroid use, which is not really unexpected. PPI use was, pretty much comparable, and combo anti-CLA4 plus anti-PD1 or PD-L1 was also comparable as well. Now, looking at the characteristics of the initial episode of AKI, again, this is the shorter duration versus the longer duration, and these are the p-values. There really wasn't any, difference between, both groups, including the time to initial episode of immune checkpoint inhibitor-induced AKI, the AKI stage, those who needed kidney replacement therapy, those who were hospitalized. I'm happy to see that, 80% or more involved a nephrologist basically in their care. The urine studies were not different as well. They biopsied around a total of 51 patients, and all of them, 100%, had acute tubular interstitial nephritis on biopsy, 13 in the shorter duration group versus 38 in the longer duration group. The median time to corticosteroid initiation was 3 and 2. Again, all of these were non-statistically significant. The median initial oral dose for prednisone was 60, which I found interesting. And then basically non-corticosteroid immune suppression, 1 out of the shorter duration received tocilizumab versus 2. One of them received Cellcept, one of them received infliximab, and then this here looks at rechallenge, which was really comparable in both groups. Looking at the Kaplan-Meier for recurrent immune checkpoint inhibitor-induced AKI or death. So this is the y-axis, and this is the percentage of patients who had recurrent immune checkpoint inhibitor-induced AKI or death. And this is the y-axis, and this is the x-axis. This is the number of days following completion of corticosteroids. Basically, as I discussed, the word completion meant that the steroids were tapered to less than 10 milligrams. And you could see, the p-value was 0.9. There were really no differences between both groups. The orange curve is the longer duration group. 12 out of 109, basically 11%, either developed recurrent immune checkpoint inhibitor-induced AKI versus death. 9 died versus 3 that developed AKI. In the shorter duration arm, 5, which was 8.9% of the group, basically developed recurrent immune checkpoint inhibitor induced AKI versus death. 3 died versus 2 developed AKI. The median time to develop either AKI or death in the longer duration arm, the median time was 5 days with an interquartile range of 1 to 18 days. And for the shorter duration group, it was 20 days, and the range was 14 to 20. There was no difference in nadir serum creatinine as well. Here, the y-axis looks at the serum creatinine. The x-axis looks at the days following corticosteroid initiation, 0 to 14 versus 0 to 28 versus 0 to 90. And as you can see, the p-values were not statistically significant. They also, looked at biopsy patients that were biopsied. The 51 patients that had acute tubular interstitial nephritis. Out of 13 patients that were on the shorter duration group, 0 developed recurrent AKI or death, and then out of 38 patients who were on the longer duration arm, 4, which is 10.5%, developed recurrent AKI or death, and the p-value was non-statistically significant at 0.56. Some of the strengths and the limitations of the study. First of all, this is a large multi-center, pretty much generalizable cohort. The only other study that I found, which I will basically discuss in the next slide, was a smaller cohort, and then the exclusion criteria were pretty much appropriate. For example, the authors did exclude patients that had actually corticosteroids. Sorry, the patients who actually passed away within 28 days of corticosteroid initiation, and that's to eliminate immortal time bias. Some of the limitations include basically recurrence of immune checkpoint inhibitor-induced AKI or death was limited to less than 30 days. I would take that with a grain of salt, because the whole idea was to try to understand basically the recurrence of immune checkpoint inhibitor-induced AKI or death in unprovoked patients, including patients that were more than basically were more than 30 days. We had to kind of differentiate between provoked and non-provoked AKI. Because of the small number of events, there was a limit to a univariable adjusted risk, actually, which did not show any predictors for AKI that were statistically significant. So they couldn't do a multivariable adjusted risk. And then there were no cancer outcomes included. This is the only study that I really found that was basically comparable, and this is by Dr. Seiss's group in Harvard, and they compared a rapid corticosteroid taper, which is basically less than 3 weeks, compared to standard of care, which is basically 6 weeks. And they used a smaller cohort, I think around 13 to 14 patients in each group. There is no significant difference in the time to renal recovery. P-value was 0.092. However, they found that a numerically higher number of patients recovered with the rapid taper, 11 out of 13, which is an impressive 85% compared to standard of care, which is 46%. Some of the other immunosuppressive medications that I found in terms of case reports, this is a case of refractory acute interstitial nephritis in the setting of nivolumab therapy. In this case, this patient had refractory immune checkpoint induced inhibitor AKI, which was actually acute tubular interstitial nephritis. And that patient was refractory to corticosteroids here. And then they used the CellCept, which basically led to a near complete response, or I would say a partial response. And then this is a case series that used infliximab as well. And these were basically 10 patients that also had acute tubular interstitial nephritis that was attributed to immune checkpoint inhibitors. And these were refractory to corticosteroids as well. And four patients developed complete renal recovery, 4 partial, and then none basically did not recover at all. So in conclusion, basically, in patients on corticosteroids for the treatment of immune checkpoint inhibitor-induced AKI, the authors found no significant difference in the incidence or the timing of recurrent AKI or death within 30 days of steroid completion. Basically, steroids tapered to less than 10 milligrams between those that were treated less than 4 weeks compared to those that were treated for 4 to 12 weeks. Basically, shorter duration of steroids may be similarly efficacious to basically, longer duration in treating immune checkpoint induced inhibitor AKI. However, we do need randomized prospective trials to basically validate these results. And then speaking of randomized prospective trials, I looked at clinicaltrials.gov, And these are the only two studies that I found. This one is basically done in Spain, and the investigators are looking into kidney damage biomarkers. And then this one is in Lyon, France, and they're looking at renal adverse effects. So I'm not aware of any study that's currently looking into any prospective study that is looking into that specifically. And I do understand that it recruitment might be very difficult because of how rare it's not. We don't see immune checkpoint inhibitor induced AKI except in the big centers that use them and the more advanced countries, but hoping that one day we would see a prospective study that would address that question. So basically some of my questions and thoughts, and I'd like to hear all your thoughts. Basically, how do you manage immune checkpoint induced inhibitors induced acute tubular interstitial nephritis in your practice? In terms of steroids, do you start with like a weight-based dose as what is recommended and like recommended by different societies? How long do you keep the patients on the steroids? Have you seen a difference between single and combo immune checkpoint inhibitor use? Any difference in terms of the type of cancer being treated? And then, last but not least, have you used any other immune suppressive medications before considering steroids, and even after using steroids for cases that were basically refractory to steroids? And I thank you, and I open the I'd be happy to answer questions and would love to hear all your thoughts.
Awesome. Thank you so much, Mo. I think we'll, considering it's a small room, I'd love to go around the room and ask about everybody's practice. But there was one question by Dr. Shirali in the chat about the prior MMF or infliximab study. Do you know what the definition of steroid refractoriness was in that study?
I do not know, but I could actually go back and look. The CellCept was a case report, and the infliximab was a case series, but I can go back and take a look, and I'll email Dr. Shirali.
Okay, why don't you update that in the chat, maybe if you're able to look it up now, but I'll go around the room. I want to get sort of everybody's experience, because the numbers are so small, so we dip in a lot on anecdotal experience, and I know the practices vary across the centers. And in our own center, we've never been burnt, meaning we use corticosteroids for most people, unless there's a reason not to, and if there's another severe concurrent IRAE or something like that. And we've never had to use other immunosuppression. So our experience varies from, say, MD Anderson or Mayo, where I think they have more experience using other agents and have had more steroid refractory cases. But I'll start with Shruti here, who's an author in the paper. So Shruti, if there's any points you'd like to add and talk about the practice at the Brigham.
Yeah, I mean, obviously this paper is, the largest study on this topic to date, but it has its limitations. It's not an RCT, as a comment was made, and we couldn't do any multivariable analyses because of the smaller sample size. We are actually hoping to do a trial soon with Meg Seiss's group as well, but it has influenced my practice in the sense that I don't treat people as long as I used to. I do tend to taper people a little bit faster. I tend to start with 1 mg per kg, but taper within 3 to 5 days, as opposed to 7 to 10 days, which might have been my previous practice. I also do think that there's utility in using things like infliximab and maybe even things like tocilizumab for really refractory cases. And I think those need to be integrated in some of these steroid refractory trials down the line as well. But I've now in 2 patients utilized infliximab in people who've had recurrent ICPi AKI on steroids rather than subjecting them to 3 courses of steroids. I'd rather add infliximab after the first failure.
That's great. Awesome. Thank you. I just want to ask Sandra. Sandra, if you're on the line, I know you've spoken about using non-invasive biomarkers to sort of decide on the duration of your steroid treatment. Could you sort of weigh in on that?
Hi, Harish. Nice to see everyone. It's been a while. Yeah, we use that even for diagnose people who don't have a significant, we don't get to worry about and even recommend resuming the therapy. But we do follow the retinol binding protein to creatinine ratio and the CRP. If the levels are okay and the creatinine is bumped a little bit for some reason, we don't think in extend and treatment. But I understand. I think it's great that you guys going for a randomized control trial, because in my experience, it all depends. If you drop too early, and like in Lin's and Ala's paper, when they use infliximab, the treatment for infliximab was 3.5 weeks. 3.5 weeks, if you stop the prednisone and start tapering too fast, they're gonna increase the creatinine, and I don't consider this refractory. But if you go, I would say a course of 8 weeks is most of the time to 0. We drop to 20 milligrams within 4 weeks, and the next 4 weeks they do very low dose, less than 20 milligrams. And very rarely I have 2 cases that they are refractory. They usually get combination therapy and then using infliximab, and still some of them, they're really hard to treat. But retinol binding protein is a very helpful tool. With CRP, prednisone does drop, but we know what's going on with the kidney. If they don't have any other injury or inflammation brewing there, it should be a very low level.
Thank you for that. And then I also want to point out that Shruti's original paper of the big cohort, one of the most important sort of predictive factors for recovery of AKI was the duration within which the corticosteroids were started, right? So I think in many of our centers, when we are seeing these patients so quickly, we have the ability to sort of diagnose quicker and start corticosteroids quicker and perhaps have a better outcome than if if you see them down the line and the creatinine is stuck, might not meet criteria for AKI, or maybe it's mild AKI and it's just like nobody sees them for like 3 or 4 weeks. That might be a patient where a longer duration might be needed.
Yeah, but the other point is also, I don't know your experience, but sometimes the oncologists take a while to call you, and sometimes the creatinine 0.9 goes to 1.2, and they, okay, let's not give the checkpoint. That has been a month, So that's why I think it has to be very careful when you do a randomized. Okay, if the patient is not being resumed the child for 2 months because, okay, creatinine 0.9 to 1.1, now it's 1.4, then 2 months later go nephrology, the duration of steroids might not be that, those are all the problems you have to put in. And I think that's why I'm not very keen to drop because as you said, we diagnose right away, and I look at the past, and you go 8 weeks, usually there is no problem, no need for more medication, only rare cases.
Awesome. Maria, if you'd like to weigh in on the European, the Spanish and the European experience, do you folks treat people any differently?
I have the feeling that you cannot drop a lot, but you can decrease a lot. You can maybe have the patient with 10, 20, that is the consideration of the 2 months, and with 10, 20, you can give again the treatment. We treat the patient without having the reflare. I have this feeling that, okay, you cannot withdraw.
Yeah, no, that's a great point. I think one of the biggest proponents of wanting to taper quickly is the fact that you can re-challenge quicker, but if you're on a lower dose, then that point might not be as important. So that's a great point. I think Maria's being cut off because she's on a high-speed train. If others don't...
Maybe you can go.
Sorry, we could not hear you.
Yeah, it's cutting.
Okay. I do want to ask Anushri to weigh in on the Yale experience. I know they were originally written on the diagnosis and treatment. I want to know if their practice has changed. Anushri, if you're on the call.
Yeah, no. So I think for us, most of the cases,
Maybe Clara could help me.
I'm sorry. Can you guys hear me?
Yes, yes, we're good.
Sorry, I thought I heard someone ask a question. No, what I was going to say is, I think for most of the cases we've seen here, they've actually all been steroid responsive. And we have had variability in some patients. We try to taper early, and my practice used to honestly be to do everyone within 28 days, mostly because these were patients who were responding well to immune checkpoint inhibition. Creatinine started going down rapidly, and the taper just intuitively as a clinician made sense. In some of those people, we had to then, go up on the steroid dose as we started tapering, because creatinine just sort of looked like it was hung up. I have yet to have a case of true steroid refractory kidney disease. The ones I've had, honestly, were referrals from oncology, because here onc tends to treat a lot of their AKIs. They tend to give prednisone to everybody, and it ended up being a patient who was in prednisone, per them failed prednisone, and then was put on MMF. And then we ended up biopsying, and it was not acute interstitial nephritis. So yeah, we haven't done much here in terms of non-steroid immunosuppression. We haven't just honestly not seen it.
Thanks so much. Others, Clara, Nashat, Priya, Karthik, Amy, any of you want to weigh in on your experiences regarding how you manage these patients?
Our experience at Sinai is pretty similar to what I think Anushri just was talking about. We haven't seen that many like steroid refractory cases, but I think oncology tends to start patients on steroids prior to even referring them to us. I have not yet used infliximab at this point, and I was wondering from the group, like for patients that are, since a lot of these patients are started on steroids prior to even coming to us without a biopsy, for starting infliximab, are you biopsying first before starting infliximab, or are you giving it with the presumption that this is interstitial nephritis?
Well, I usually biopsy people. I don't have much that issue. That's my big problem with all those retrospective trials. Like, how can you say? I have a lot of people, I have biomarkers biopsy. A lot of it is ATN. There is no need. So I'm a little bit.
Yeah, I would always make sure that they have a biopsy before I give infliximab, and it'll be someone who had biopsy
That's what I was
proven.
thinking too. Thank you for the group's advice.
Yeah, I would usually, if somebody has suspected AIN, I'd biopsy them, I'd treat them with steroids, and then if they have recurrence, I don't need to biopsy again if their creatinine goes up if I had that initial biopsy. If I didn't biopsy them the first time, then I would definitely biopsy them the second time that they had AKI before giving them infliximab.
Problem with biopsy after prednisone, I have a couple of cases that it doesn't show much of inflammation. It's more ATN after the fact. Pathology report, oh, there's not much inflammation, but then it was interstitial nephritis. So for those who are not used to that, you have to have a high suspicion, have the biomarkers there increase, and then you can see they respond beautifully to prednisone once it recurs. So that's why our problem is oncologists if they start earlier prednisone, but in general, I usually biopsy those who are concerned with other drugs. You can do empirically, but you have to know that they have to be clear for any other factor that you might be causing the AKI.
Oh, that's great. Does anybody sort of preemptively decide to treat for longer? Are there certain characteristics that would make you decide that, this particular patient is going to need a longer duration of steroids? Or does everybody just look at the response in the first, say, few days and then decide on the taper? Do you have a practice that goes one way or the other?
I tend to look at what happens in the first few days. I think that, at least for me, anecdotally, it seems to predict whether someone's going to need a longer or shorter duration.
For me, if it's severity, like if I have a patient who has like a 3-fold rise in their creatinine, or they're, almost on dialysis or are on the dialysis, then I usually treat them slower and with a higher dose.
Yeah, I give IV. For the ones who come ambulatory, I usually do orally. But those who hospitalize and more severe, I give IV higher dose, but usually treat as the same process.
IV as in a couple of doses of pulse steroids, or just 1 mg per kg?
Yeah, I just give metoprenzolone just once, and then like next day creatinine if they stop or improve rapidly. Depends on the situation. I usually do 1 or maximum 2 days on metoprenzolone for those hospitalized cases, but in general, they respond well.
Hi, Karthik here. Quick question regarding the retinol binding protein. I'm yet to kind of send one. How frequently are you using that? I know Mayo uses that a lot, but other centers, are you using that as a tool to kind of gauge your response to therapy, or in general to diagnose? Versus like how much time does it take to come back? Because I'm pretty sure like it's a send out test, it'll take at least 7 to 10 days minimum.
If it takes that long, we're probably not using it. But Sandra, I don't know how long does it take for you guys to come back? I'm pretty sure it's much quicker.
For us, it doesn't come the same day. Usually it's next day. They do a few times a week. So that's not my main point, to go, but does help for the case they're not really acutely elevated and should we biopsy now? Should we? But the problem, I believe, in America is Mayo is the only center who doesn't, so you're going to have to send to us. So that's the disadvantage. But you can talk to your renal lab, and then they can, it's just a question. You see how much you use. And it's not only for any case of interstitial nephritis. We are using here, and my colleagues with checkpoint for all their cases, it's been quite helpful.
I think we have a couple of questions here that I'll post to the group. If you do use IV methylpred, are you using 250, 500? What dose are you using? That's question 1. I personally would just use 250. I don't think you need.
Yeah, me too. Usually 250. I think in the first trials, when they started, they had the multi-organs. I remember reviewing the notes, and it was like 1 gram, like there was one patient, but 1 gram 9 days in a row. But he had GI, renal, had multi-organ effect, but it was like, I think they didn't know what to do in it. But the patient survived.
The second question I think is super interesting from Nashat, because I think this is a question we've all sort of struggled with, is the whole effect of immunosuppression on, what happens to the cancer itself, whether it's associated with progression or whether there's no association. I think the data is sort of conflicting. I guess I'll post to the group, what have you heard from your oncology colleagues? Are they more hesitant to use more steroids, or are they not as hesitant? What have you seen in your practice?
At Yale, I don't think any of them show any reluctance to using steroids. I think most of them actually don't think it actually has an anti-immunotherapy effect. There's a lot of controversy, I think, in the oncology literature about that. So here I've never had them. And what they say to me is, improve the kidney function as much as you can, and then we'll collectively make a decision about whether the patient needs redosing.
Yeah, I agree with Anush. And that's for my question of why be so fast with the temporary, why you want to re-challenge. At least my oncologists, if the patients respond, if they do the CAT scan thing, they don't give a checkpoint after, if they're responding, why do you have to why do you have to taper fast? They don't seem to be worried. So that's think about the short tapering. It doesn't seem to be a worry, like 2 months for them if they don't get the 1 dose or 2 of checkpoint. What I see for those, they have been like several months.
Mine used to be worried. So, sorry, but mine used to be worried because in my hospital,
It's hard to hear.
Sorry, Maya, I think you're really cutting off. I don't think we can hear you at all.
Are randomized in clinical trials.
Oh, okay.
Yeah,
So we
maybe
not go
for
through
the
trial,
trials.
or you are out of, I will write it back.
Yeah, maybe because of the trials, but I know real world, they are not like, I've been some patients and those who I'm using infliximab, they're just continue in remission and you know, like the oncologist doesn't seem to, maybe clinical trials because they wanted to get that met, but I think we treat so many real world that doesn't seem to be a worry.
I think it also depends, right, what stage the patient is in, right? When we first saw these patients, they were all stage 4 refractory to prior chemo. It's different now. A lot of these are early stage malignancies. So I think it depends. And I think in those cases, an oncologist is going to say this is supposed to be maintenance treatment. So no, like
Or they have other options.
That's right. Or there are other options. That's
Yeah.
right. So it's not, I think, a one size fits all. It's
yeah, but I they don't seem to be worried with the steroids.
That's right. Yeah, I agree with that.
My impression.
Yeah, no, it's the same thing here, Sandra. I've not heard a single oncologist say get them off the steroids because I'm worried it's going to have an impact.
They just wanted to get the kidney as complete remission as can, because then they are more able to get on other clinical trials. As this is another issue we have to deal. Our patients CKD or low kidney function, they are not, you know.
That's a really excellent point.
That's the main thing they want. So usually don't have problem, but I think that's the issue.
Right.
Yes, I see the RCT point. I think, you know, one of the other things is if you like all the oncology guidelines, as we know, as we've written in all our papers, is that once you get a grade 3 AKI, you just like stop the drug. That's like, you know, but nobody does that now. Like hardly anybody even suggests stopping the, they'll be like, okay, let's see what happens. Cancer is stable, you'll hold off. But nobody has any hesitancy in like restarting the drug as they used to have. Even in some of the most severe immune-related adverse events, you might say, hey, let's put the patient on steroids while we give the drug, but almost always, you know, you're able to like provide.
At least for the kidney, for the heart, if
Right.
it's myocarditis, that's the stop, you know.
Hard stop.
Yeah.
Yeah. I wonder though, right, you're right. I think here I've had no issue with them doing re-challenge. But the community docs, right, are probably the ones that are going to be following those guidelines. And so it'd be, you know, interesting if we could give more input on some of those guidelines. So because you're right, I think academic centers, the re-challenge is much more likely.
The other thing I do want to point out is the whole like biomarker thing. I think there's more and more coming out. I know that Dennis's work at Yale about like urine TNF alpha and some of the interleukins, and Sandra's work at Mayo, and there's like gene signatures that are coming out. I think there'll be a lot more in the next few years, which I think will be super helpful, because I think a lot of the initial hesitation is around diagnosis and starting steroids earlier. So if we have really good biomarkers that are like widely accessible, then I think it makes it much easier to give steroids or shorter courses, or even like look at like how severe the disease is if you can non-invasively do that. So hopefully that'll come as time goes. Okay, awesome. Any other questions and points for discussion? I guess I have to ask Sandra, like when do we get to talk about our own ASON guidelines on ICI nephritis?
I beg your pardon?
When do we get to talk about the ASON guidelines on ICI nephritis?
Oh yeah, about the position.
Yeah.
Yeah, we are dealing with the GFR one, and that's why we need to finish and submit that one, which will be May, hopefully. But that one, you're gonna get emails about that too. But we really need this GFR it's taking a lot of work beyond that we thought.
Awesome.
But hopefully May, June, we get a May for after that, and I think we got a good experience in doing this one.
Awesome. Any other questions, anyone? Okay, awesome. Thank you so much, everybody, for joining. That was a very crisp session, but super useful. And I hope we can write some of these points down and make it a J1 article. And thanks, Mo, for presenting, and Amy for arranging all this.
Thank you.
Nice
It's a great
to see
idea to do
everyone.
a journal club.
Bye.